Hi, my name is Elizabeth Linton. I am in Dr. Barmgottle's class, and I am going to be doing a case study on hypertension. Okay, here we go. Mr. Job Eden is a 73-year-old African American man with a medical history significant for coronary artery disease and stage renal disease, type 2 diabetes, and hypertension. Mr. Eden reports to the emergency department for a severe headache, dizziness, malaise, and general periods of shortness of breath. Mr. Eden also reports that he has had an increased level of stress as of late due to being in between jobs. He also reports his dietary habits include eating meals from fast food restaurants 6 to 7 days per week and has recently taken up smoking and alcohol intake to cope with his stress. A few things going on here. It doesn't appear that Mr. Eden is a very healthy individual. Unfortunately, the first thing we need to do is rule out a stroke. Patients presenting with severe headaches may be having some type of stroke, especially if accompanied by additional findings such as dizziness and malaise. Another differential diagnosis here would be that Mr. Job has previously developed a blood clot secondary to his coronary artery disease. He reports feeling shortness of breath. We would need to rule out any changes that have developed a blood clot that somehow dislodged and may now be a pulmonary embolism of some sort that would cause him to be short of breath and feeling this malaise. Taking into account his history of diabetes, I'm not thrilled that he has such poor dietary habits. He's eating fast food at an all-time high. Being that he knows that he has diabetes and is still making poor decisions, it makes me wonder if he's compliant with insulin or if he takes it at all. I would wonder if he might be in some sort of diabetic ketoacidosis that could definitely cause him to be feeling dizzy and short of breath, from trying to blow off all that acid. With such high electrolyte imbalances that occur in diabetic ketoacidosis, patients frequently do complain of pretty bad headaches. Another possibility that I would want to work through would be the status of his kidneys. I'd want to find out if he undergoes hemodialysis treatment. It's likely that being that he's in end-stage renal disease, it's likely that he does have dialysis. If he does, has he been to treatments lately? Is he taking in all this alcohol to cope with his stress? It may be that perhaps he's grossly fluid overloaded and his body can't function properly through all this additional fluid that it's not used to. Additional volume in the body can lead to a higher blood pressure and certainly shortness of breath if he's already in renal failure. There's also the possibility that he is just experiencing stress migraines, cluster headaches. He's in a high period of stress right now. He's in between jobs. Money isn't consistent and he likely doesn't have health insurance right now. So the intake of alcohol and starting of smoking is definitely not good for his blood pressure, not to mention his poor eating habits. He's turned into a very unhealthy man just because of that added stress, and he's unable to cope with that in a healthy manner. Could definitely be all of the stress. Coronary artery disease is the leading cause of death in the world today. It's reported that most deaths related to coronary artery disease are a result of hypertension. Those with hypertension are at a very high risk of being burdened with diabetes and end-stage renal disease. So it does make perfect sense that Mr. Eden has both of these. It is not surprising at all. When one or the other is not properly controlled, we have the perfect formula for this downward spiral. The smoking, the drinking, it goes hand in hand with hypertension. Mr. Eden states that he started smoking and drinking to help him cope with this high stress that he's going through of his inconsistent employment. Hyperthyroidism, when uncontrolled, also leads to high blood pressure. Thyroid medication is very delicate balance, and if he's not taking his dosing properly, it can lead to elevated blood pressures as well. Unfortunately, African Americans are at a much higher risk for hypertension and even higher risk for being unsuccessful in controlling their blood pressures and remaining medically compliant and adjusting modifiable risk factors. High sodium intake certainly does not help Mr. Eden. He's already has that decreased renal function, but it definitely also takes a hit to his cardiovascular system. When we take in all that increased sodium, our body absorbs the salt and then the water follows. We'll talk about that later. So when we have high sodium levels, we're holding that salt and the water comes with it, and that increases our vascular resistance. So naturally, it also increases your blood pressure. It also leaks into our extracellular spaces, and where we hold it, and that causes swelling and makes us, sometimes more thirsty. And with his history, we can see that water is not always what he's going for. He's also going for that alcohol. So it sounds like he's in a perfect storm for a hypertensive crisis if we don't get him some help. Not to mention he's 72 years old. The older we are, the harder it is for our bodies to kind of bounce back and normalize. He also has all these comorbidities that we just, worked through, and maybe even more that we don't know about. So the definition of hypertension typically starts with systolic blood pressure of 140 or greater and a diastolic of 90 or higher, or if the patient reports using antihypertensives. We have two stages. Our first and primary stage of hypertension is when the systolic pressure is between 130 and 139, and the diastolic ranges from 80 to 90. That's the new AHA guidelines. Second, or stage 2 hypertension is when your systolic pressures are reading higher than 140 and diastolic are higher than 90. Job has this history of coronary artery disease. It's a huge risk factor for hypertension. When someone with previously diagnosed coronary disease starts down this slippery slope of eating foods with high fat, and then they go down the path of smoking and alcohol abuse, it dramatically increases the likelihood of hypertension. So this downward spiral starts off due all because of the endothelial injury to the vessels, which then results in a reduction of that shear stress that we have that allows the vessels to kind of like stay slippery. Once this happens, now we're almost guaranteed to see plaque formation, which makes the diameter of our vessels even smaller, and this causes a rise in blood pressure. So you can think about a water hose flowing freely, and then when you step on it, it shoots the water out much faster. That's what's happening to our vessels when they are narrowed by plaque, and it causes your blood pressure to increase. So Mr. Eden also happens to miss his dialysis treatment like we suspected. This absolutely contributes to his high blood pressure. The dialysis removes all that excess fluid and the acid, and it helps keep our hemodynamic state in a regular balance. Our friend unfortunately has diabetes as well. As we said earlier, his poor lifestyle decisions lead me to question his medical compliance. If he's eating poorly, drinking a lot, his blood glucose is likely also very out of whack. If he takes insulin, is he compliant? Even if he is compliant, you still have a high, like peaks in your blood sugar, your blood glucose. It's very damaging to the inside of these cells, which, like we discussed, puts the heart vessel at risk for narrowing because of the endothelial damage. It's a problem, and it causes the rise in blood pressure. In addition, Mr. Job reports he's been out of his thyroid medication for quite some time. He has no income that's consistent, so he also doesn't have health insurance. So when our thyroids are overactive, it also can cause a peak in your blood pressure. Here are some common diagnostic studies that can be performed. Some of them don't necessarily say, yes, I have hypertension, or no, I don't, but it certainly helps us come to the diagnosis of hypertension. So typically we might get a CBC, complete blood count, to see where our patient is as far as cell counts, hemoglobin, hematocrit, platelets. That's, like I said, not necessarily diagnostic values, but by itself, but we do like to get this as some kind of baseline going. Another laboratory value we definitely want for our friend Mr. Job here is a CMP, a complete metabolic panel. He has a lot going on with comorbidities. We want to know the value of his electrolytes, sodium and potassium for sure. If these are out of whack or out of balance, then it certainly causes stress to the heart. This lab panel will also tell us what his kidneys are looking like. It'll reveal to us any acid-base imbalances, which, like we discussed, can also alter our blood pressure. He's an end-stage renal dialysis patient who may need emergent dialysis to filter this acid out or correct that imbalance, just depending on how severe things are looking. It'll also show us the anion gap, which might help us diagnose some diabetic ketoacidosis, or say, no, he doesn't have that. A BMP won't tell us if he has hypertension, but it will certainly tell us the condition of his heart and if there's any risk for heart failure present, or maybe he's fluid overloaded. That would help alter his blood pressure a little bit. For Mr. Job specifically, we would add on a TSH level. As he has a problem with his thyroid and has not been able to take medication, we want to know where he's at with that, and is that contributing to the high blood pressure. An echocardiogram and EKG, not going to tell us if he has hypertension, but it will help us to understand what the chambers of his heart are doing, how they're working. Are they pulling their weight with their ejection fractions like they're supposed to? It'll also tell us the conduction system of the heart. Is there a problem? Is there an abnormality there that we need to address? So it's just very low energy diagnostics with a high yield of information that we would like to know. What we really need for Mr. Job to do is take his blood pressures at home over several weeks, and then follow up with us in the clinic, or come back to the hospital, whatever he's got to do. We need to see the trend in his blood pressure on a regular basis. It may be that the hospital is causing him to just have nervousness and his blood pressure is rising, and we don't know. So we just need to see a trend in what his blood pressure is doing to make a better plan for him. Like we discussed, hypertension is held accountable for most deaths that are related to coronary artery disease. Of the reported deaths, 3/4 of those occur in low middle income countries or areas. Almost 1.5 billion people suffer from hypertension, and shockingly, less than 14% have their hypertension controlled. In the lower middle income areas, that percent plummets to less than 8% who have hypertensive or antihypertensive measures to control their blood pressure. The World Health Organization has focused on routine guidelines for those areas, and they're working to provide the most up-to-date practices to those areas specifically. And unfortunately for our friend, research tells us that African Americans are disproportionately affected when it comes to not being able to pay for their doctor visits and their medications. This is largely due to the absence of employment, like our friend here. Literature also tells us that Blacks predominantly don't live in the most advantaged neighborhoods where doctors' offices and good quality healthcare are easily accessible. And finally, unfortunately, 75% of African Americans suffer from hypertension before they even turn 55. And that is shocking. And African American men are the leading group who suffer from myocardial infarction related to hypertension. So our friend has a lot stacked against him here. Being that Mr. Eden already suffers from CAD, coronary artery disease, he has a lower threshold to start antihypertensives, as guided by the World Health Organization. For the goal for patients with this comorbidity is to achieve a systolic of 140 or less with a diastolic of 90, and then adjust medications from there. There are many different kinds of antihypertensives. These are just a few. We have the beta blockers that end in LOL. They slow the heart rate and increase that myocardial contractility. We also have ACE inhibitors that likely end in pril, lisinopril. They inhibit angiotensin 1 to converting to angiotensin 2, so they block that. transition there, and that helps the heart to have less of a workload. Calcium channel blockers, they block those calcium receptors and allow the heart to relax, which will also lower that blood pressure. And finally, ARBs, they end in sartan most of the time. They block the action of angiotensin too. So they reduce the vasopressin, which increases your blood pressure, along with many other things. And also with warfarin here specifically, they block aldosterone secretion, which is what makes that kidney hold on to the sol, which then holds on to the water. Diuretics also in certain cases can be used. For non-pharmacological, we want to fix his eating habits. The DASH diet is the dietary approach to stop hypertension. That's going to include fruits, veggies, low fat, no fat, whole grain, low intake of red meats, really decrease your concentrated sweets. Diets low in sodium are highly recommended with those with hypertension, especially those who have coronary artery disease and renal disease like Mr. Job. Studies show that reduction in carbohydrate and high fat intake are beneficial in aiding in weight loss, which is helpful for the heart. However, patients who suffer with cardiovascular disease, it is extremely important to monitor that fat intake and maintain that nice equal balance of carbs, fat, sodium to keep the body fueled. When Mr. Job is compliant with all of this and adheres to his medication regimen, he is going to have a much healthier life and have a very good prognosis for hypertension control. Finally, our teaching plan and projected outcome. Mr. Eden reported to us that he gets nervous going to the hospital doctor's office. This might cause him to have something called the white coat syndrome. It basically just means that when patients are uneasy in the office, their blood pressure is falsely higher than what it would be at home. So like we talked about, we need him to keep a record of his blood pressure in spaces that he's comfortable in, such as his home, wherever he's more comfortable. Most importantly, when he does get those antihypertensives, we need him to monitor his blood pressure before each and every medication. If the reading isn't in the parameters, we certainly don't need him taking a blood pressure medication to have him have a syncopal episode or whatever that may follow after that. So we definitely need him to take it. In some cases, it would be beneficial for him to take his blood pressure after the dose. So is this working? Do we need to up his dose? We just really need him to have tight monitoring of his blood pressure. He will need to majorly rethink his eating habits. Fast food 6 out of 7 days, not good. So we'll recommend that DASH diet we talked about, low sweets, low sodium, low fat, and also be aware that he's a 72-year-old guy. We can't change everything. We can't change that he goes to the McDonald's, but we can say you can get a salad versus a cheeseburger. Finally, we would like to have him exercise. He is 72. We don't need him to run 3 miles every day. Maybe every other day he can walk for 20 minutes, and that would be beneficial. Including him in these plans gives him a sense of control over his body and his health, and then he will be more likely to participate and keep up with it. So it's really important to involve him, and then when he does all of this, he'll probably have feeling better about himself. He's going to have more control of himself, and he'll definitely have a very good prognosis for managing his hypertension. This is my references page. Thank you for listening, and I hope you learned something.